Hello, everyone. My name is Matias Manzotti, and as a geriatrician, I have the great honor of introducing Professor José Alberto Avila Funes, who is an undergraduate and graduate professor of geriatrics, and his main line of research is frailty and cognitive decline. He is a researcher associate of the Psychoepidemiology of Aging and Chronic Disease team of the French National Institute for Health and Medical Research. He is also a member of the National System of Researchers and of the National Academy of Medicine of Mexico, as well as the Latin America Academy of Medicine for Older Adults. He is currently the leader of the geriatric service at the National Institute of Medical Science and Nutrition Salvador Subirán in Mexico City. Today, he will enlighten us with his position about older adults with HIV, a new challenge for all. So please, Professor, take us on the trip. Thank you.
Hello, and thank you, Dr. Manzotti, for your kind presentation. And thank you very much for being present at this plenary session. First of all, I want to thank the organizing committee of the Congress for its kind invitation, and I want to express my gratitude for the honor that I have been given by speaking in front of you in this 22 World Congress on the International Association of Gerontology and Geriatrics 2022. And today I want to share with you the experience of our work with other adults living with HIV as well as frailty, which we have now directed towards a special group of people whose number grows day by day. Let me share my screen with you. Okay. In recent years, in our hospital, which is a third-level university hospital, we were able to see how people living with HIV and how our younger began to complain about health problems very similar to those seen in the geriatric population, such as memory complaint, decrease in physical activity, greater disability, etc. It is then that we realized that the greatest survival of these patients will lead them to develop other additional health problems related to aging and HIV itself. In this way, in cooperation with the Department of Infection Disease and Immunoinfectology of our institute, we began to focus on these people and to apply the activities of geriatric practice in them. It is from this experience that I want to talk to you this morning. This is my agenda that I will share with you. We will talk about the situation of older adults living with HIV. I also will address some words about the concerns we have in geriatrics for this group of people, including frailty. In the end, I will try to give a final message about the importance of our specialty in the attention of people living with this infection disease. Well, the first question that must be answered is to know why we, the geriatrician, should be interested in this infection disease. First, older adults living with HIV are a growing segment of the population, and aging with HIV is a global phenomenon. Usually, the diagnosis of HIV infection is normally delayed in this group of people. And normally we think of other diagnosis options before suspecting that another person may have HIV. We consider always cancer of psychiatric disease before. It is also necessary to highlight the need for multidisciplinary care in this population, which is normally done, but it is clear that health systems need to be adapted for this unprecedented phenomenon, which is the aging of people living with HIV. Undoubtedly, the access to combined antiretroviral treatment has been remarkable in the last years among people who acquire HIV. Access to treatment has been reflected in a marked decrease in mortality of these people. The disease that was previously a death sentence is now become another chronic disease which has specific needs. Aging with HIV is now a reality, and in some countries, such as the United States or Canada, the proportion of people from 50 years or older living with this virus is already greater than 50% of all cases. This has created new challenges for the care of this population, and at this time, it is already clear that the treatment goes go beyond the only control of the infection. We can say that a consequence of the success of treatment for this infection by an effective control of the disease is the fact that people who acquire HIV in early age can now aspire to aging. Aging with HIV is not only possible, it is a standard. Although most incident cases remain in younger people, older adults already concentrate more than half of prevalent cases. Aging with HIV should be the standard for all the patients living with this virus, and it is possible that in the next 10 years, in the countries where the pandemic began, the United States or Canada, for example, the proportion of people from 50 years and older living with HIV exceed 75%. And this change is one of the arguments used to say that HIV is already considered as a chronic disease. And as this graph from the United States illustrates perfectly, will be a problem that will affect especially older adults. In the rest of the world is not indifferent to these epidemiological changes. In Latin America, the trend is very similar, and there is a significant growth of the proportion of people having HIV or older living with HIV, not only to the aging of those who become ill during youth, but also by an increase in new cases diagnosis in this late stage of life. However, although it is a new standard that these people have a life expectancy very similar to those who don't have HIV, it is a reality for all people? And the answer is probably no, because the mortality reported, as well as the life expectancy, has been very heterogeneous, in which factors such as achieved biological suppression, the nature of CD4 lymphocytes, the time from the diagnosis, or the presence of comorbidities are responsible of a very varied mortality rate in the different cohorts across the world. On the other hand, another reality is that the cause of death of these people is currently due to condition associated with HIV and not with AIDS itself. This is very important observation, partially explain why our specialty should be involved in the care of these patients. With the passage of the time, it has been observed that people living with HIV atypically develop very early a series of disease that health problems that are normally seen in old age. This observation has led to propose that HIV infection can represent an accelerated aging model. And in fact, HIV could be an accelerated aging model, but also an accentuated aging model, since the people affected, as previously I said, develop health problems usually seen in older adults, but in the earliest stage of life, such as greater frequency of cancer, cardiovascular disease, chronic kidney disease, cognitive impairment, or osteopenia. And in the same sense, an early development of geriatric syndrome has been identified, which has gained more relevance in recent years. In this way, HIV infection can promote and accelerate aging, since we identify more geriatric syndromes or more age-related conditions among people living with HIV before the expected with a population. But it is also true that compared to people of the same age, but without HIV, the frequency of geriatric syndromes among people living with HIV is much more important. This distinction must be clarified in the coming years when we can develop better techniques for the measurement of human aging and distinguish if it is an accelerated aging or an accentuated aging by the HIV. It is obvious to think that people with AIDS or uncontrolled disease will suffer more health problems. However, even in people who are achieved by the treatment goals of combined antiretroviral therapy, such as having an undetectable viral load in those older adults living with HIV, the frequency of geriatric syndromes is more important. In this work, in this slide, we can see that there is physical frailty in 1/3 of participants, as well as disability for at least one instrumental activity of daily life. In the case of our region, our multicentric cross-sectional study, including 501 Mexican community during adults aged 50 years or older living with HIV and all under CERT, combined antiretroviral therapy, showed that polypharmacy, sensorial deficit, cognitive impairment, physical disability, being frail and falls were the more prevalent geriatric syndromes, and the 25%, one-quart of participants had at least 3 geriatric syndromes. Then why? Why do younger people develop health problems from older people? It is just for living with HIV, or is the result of a synergistic effect between aging and HIV? It is very likely that the development of geriatric syndromes among people living with HIV are the result of at least 2 physiological hits. A first hit detonated by the aging process itself and low-grade chronic inflammation related to age, and a second hit is detonated by inflammation due to HIV and the series of physiological changes reported in this population. So second hit is given by the retrovirus itself, and despite the proper treatment of the disease in most people living with HIV, there is also evidence of persistent inflammation and immune system dysfunction. That's it. Despite good treatment, it seems that the person who lives with HIV is not restored to its basal state. They do not return to their physiological state prior to infection. And this phenomenon could also promote the decline of the immune system and also contribute to the perpetuation of low-grade inflammation resulting from the combination of different factors. For example, viral replication in sanctuary sites, or infections, or, for example, cytomegalovirus, or change in the microbiota. Thus, a combination of these mechanisms are behind the development of geriatric syndromes, which are frequent among older adults with HIV. Undoubtedly, frailty is one of the most outstanding issues for this population. Frailty is a crucial issue within geriatric medicine. However, the term, as you know, remains controversial. We have not a universal consensus to define frailty, and there is also the debate of if exist different types of frailty. However, most of us agree that referring to frailty, we are talking about a loss in the ability to maintain homeostasis and poor resilience against environmental stressors, which detonates the appearance of multiple adverse health-related outcomes. And this state, the frailty status, has initially described among older adults, and their interest in research is not only because of its serious consequences for health, but it has been shown that it can be prevented, treatable, and potentially reversible. Therefore, it is crucial to catch frail people before they have complications such as disability. The origin of frailty is unknown, and surely it is a multifactorial phenomenon, and its underlying physiopathology includes dysfunction of multiple systems and involving neuroendocrine system, the metabolism, musculoskeletal system, and the deregulation of immune system where inflammation plays a central role. An HIV chronic infection can trigger the same immunological roots described for frailty, and in this way, people or frail people have an inflammatory firm, which includes alterations in reactive C protein, interleukin-6, or alpha tumor necrosis factor. It is not easy to be able to distinguish those changes in the immune system due exclusively to the passage of the time or a particular condition such as frailty or HIV, since many similar physiological changes has been identified in people with these different problems. These mainly include changes in the cellular immunity and are those that you can appreciate in this table. I insist once again, these inflammatory changes, this physiopathological signature is that perpetuate the chronic and low-grade inflammatory state, which has been involved in the origin of the multiple changes seen in the system among people living with HIV, which include the endocrine systems. I emphasize the endocrine system because this can explain many of the things that happen in frail older adults. However, these changes in the endocrine system also explain many of the findings seen in people with HIV, as it happened among the frail seniors through a complex interaction between defects in the immune system, chronic and persistent inflammation, oxidative stress, and a multiple anabolic deficiency that converge in alteration of insulin-like growth factor number 1, which stand out as a key element in both problems. But why? The insulin-like growth factor number 1 is a growth hormone mediator in different tissues, such as muscle, bone, and fatty tissue. And the decrease in the production of the insulin-like growth factor number 1 leads to the decrease in muscle mass, an increase in visceral adipose tissue, and a decrease in bone mineral density, which has clinical translation as the presence of visceral obesity, sarcopenia, and osteopenia. In short, the development of an early somatopause. In older adults, it is well known that these changes are risk factors that act independently or synergistic for the high incidence of adverse health-related outcomes, including frailty and disability. Somatopause, sarcopenia, and immunosenescence has been identified as pillars of frailty physiopathology. Therefore, it is expected that the presence of these factors bound to the effects of HIV for long periods of the time, or coupled with a no-control disease, could lead to the development of these same adverse outcomes, among which the most fierce is included. That means the functional decline. In the same sense, some years ago, Dr. Luigi Ferrucci and collaborators have also proposed a multiple underlying mechanism for the emergence of chronic low-grade inflammation. That means the inflammation, which includes everything already mentioned previously, and the appearance of visceral obesity, changes in intestinal microbiome, and the increase of permeability of intestinal wall, as well as the presence of chronic infection such as HIV. In this way, this chronic inflammation of low grade, the inflammation is responsible for the development of so-called disease associated with aging, such as cancer, and in turn to the development of geriatric syndromes, including disability and frailty. Thus, the appearance of the geriatric syndromes of frailty could be the result of the interaction and contribution of the changes triggered by the aging, as well as of the comorbidity that usually is present with the advances of the time, the effect of the HIV, and even of the adverse effect of combined retroviral treatment, which has not been discussed here, but this is a very interesting, since it seems that, in fact, the survival of people living with HIV in a very important way increased, but at a high price. But this is another history. In summary, frailty is a multidimensional. Frailty is multidimensional, and frail people living with HIV seems to be the result of infection itself, the contribution of multimorbidity, and environmental and social factors. This is how HIV has a negative synergistic effect with aging on various physiological spheres, and even social, which can lead people to develop multiple complications and die early. Let us not forget that as people live more, it is more risk of developing another condition, including immunosenescence, which in turn increase the risk for other incident conditions. As I have previously said, frailty is an undesirable physiological state in old age, and we should strive to identify and implement measures to modify its disastrous trajectory towards disability, dependence, poor quality of life, and death. Therefore, we can deduce that it is useful to establish measures to identify frailty among a group of people who identify as even more vulnerable as are the older adults living with HIV. Because the chronological age alone is not a good predictor of people's health needs, it seems more useful to identify the presence or absence of physiological states of risk, such as disability. And this has already been demonstrated in many disciplines, such as oncology or surgery, where identifying those people with frailty will result in a benefit for the patient. In this way, it should be started with a different clinical approach for these people, as well as creating specific care models made to measure a tailored model. That's it, based on individual health needs. However, it continues as one of the most important challenges to establish an universal control of frailty, and this problem is also present for the identification of frailty among people living with HIV. And different approaches has been proposed. The phenotype of frailty has been used, and the phenotype proposed by the Johns Hopkins group 30 years ago as everyone knows, is one of the most used, have great acceptance, but is criticized phenotype for not including all the components that presumably make the frailty concept and focus only on the physical frailty. However, for several years, a phenotype related to frailty applied to people living with HIV has been used. On the other hand, the index of frailty proposed by the Halifax group, which represents frailty through the accumulation of deficits, has already validated by its application among people living with HIV. And more recently, the VAX index has been also used, which involve biological markers and predicts mortality and others unfavorable undesirable outcomes. However, depending of the objectives that we want to achieve, particularly in the area of clinical and epidemiological research, any of these proposals should be used. What do we know about the epidemiology of frailty among people living with HIV? The information available comes from very heterogeneous studies and that have included different populations. For example, with user of intravenous drugs, men who have sex with other men, etc. And the information also comes from different definitions of frailty. Therefore, the prevalence will depend on the cohort of the origin and the definition used. This is how frailty has a prevalence between 4 or 28% according to the literature available, and this data the data come mostly from Europe and the United States. In our experience in Mexico, we have the lowest prevalence, probably due to the characteristics of our institution. However, many confounders need to be evaluated. Nutritional factors, treatment, diagnosis, duration of cell status, experience with combined retroviral therapy, for example. A relevant observation has been the decrease in the prevalence of frailty among people living with HIV through the time, particularly since the introduction of the combined antiretroviral treatment. This effect is very clear when analyzing the results of the MAX cohort, where it's observed that a better immunological state associated with a better treatment is related to a lower frequency of frailty. However, even with the best treatment available for that time, frailty was present in a very young population. And findings like this contribute to the hypothesis that there are other underlying factors at the origin of the geriatric syndromes among people living with HIV beyond the achieving of immune reconstitution. Therefore, the prevalence of frailty among older adults living with HIV is comparable to that found among people with HIV, but who are a decade older. This finding is very relevant. This graphic illustrates how the determinants of frailty have changed over time by showing a U-shaped curve. At the left side, the prevalence of frailty is more important among those people who have a no-control disease, and this represents by the presence of a detectable viral low CD4 lymphocytes counts, and the presence of definitory AIDS disease. On the other hand, at the right side of the graphic, the prevalence of frailty is also high in people with better immunological status, but have other features such as being older or having a greater number of chronic disease. In this sense, low persistent chronic inflammation attributable to both HIV infection and human aging will favor the development of geriatric syndromes when the balance between these two factors is lost. In the last decade, with the appearance of the phenomenon of aging among people living with HIV, multiple studies have begun to identify the associated factors and frailty predictors in this population, obviously with the purpose of identifying it early. For example, in this slide, we can see first as the frequency of frailty as well as the risk of developing frailty is more important among people living with HIV compared to other people of the same age, but who live without HIV. According to the results of the study ALIVE, the risk of developing frailty is almost 70% 70% among people living with HIV compared to those with life without HIV. In studies that have analyzed HIV-related factors, there are also intuitively expected results. For example, the lower number of CD4 lymphocytes has been found as a correlate for the incidence of frailty during a stage of Dr. Loic de Kilve within the group of Dr. Linda Fried in the United States. He had the opportunity to apply the phenotype of frailty in men who have sex with men, what are very young and participate at the max cohort. He called this phenotype as phenotype related to frailty or frailty-like, and he was able to demonstrate how the decrease in CD4 lymphocytes counts increase the risk of frailty, being the risk most important when immunodeficiency was deeper. On the other hand, it was also demonstrated that the high amount of CD4 lymphocytes counts was associated with a decrease in the risk of frailty, even among people with good immunological condition. Therefore, the number of CD4 lymphocytes counts is a good predictor of frailty, even in control people and with an detectable viral load. And this work also showed that the prevalence of frailty is much more important in those with at least with the least amount of CD4 lymphocytes count. Another marker frequently used in specialized literature is the ratio between CD4 and CD8 lymphocytes count. This work of our colleague Fatima Brañas in Spain showed that a good immunological condition represented by a high CD4-CD8 ratio was inversely associated with the risk of developing frailty up to almost 90%. On the other hand, this work by Dr. Giovanni Guaraldi in Italy has shown an inverse relationship between the results of the index of frailty and the ratio of CD4 and CD8 lymphocytes counts. In the same sense, our group has also demonstrated the usefulness of the CD4-CD8 ratio, but this time it works to predict the development of functional decline. Therefore, this ratio is also useful for predicting adverse health-related outcomes among people living with HIV. On the other hand, other factors have also been identified as predictors of frailty in people living with HIV. Beyond those derived from the infection, and these seem to be the same view among older adults with HIV. These factors include the advanced age and the presence of certain patterns of demographic characteristics, such as a low educational level, poverty, unemployment, and belonging to certain ethnic groups. And as it has been demonstrated among people living without HIV, the presence of rate in people living with HIV is also an important and strong predictor of adverse health-related outcomes compared to people of the same age, but do not have frailty and who do not have HIV. These adverse outcomes include a higher frequency of hospitalization, greater number of falls, higher mortality, and a greater development of chronic disease. Also, the presence of frailty among older adults living with HIV brings a higher risk for the development of other outcomes of interest in geriatrics. In this cross-sectional study, we were able to demonstrate that the presence of frailty is associated with a higher frequency of neurodegenerative disorders associated with HIV, particularly the mild neurocognitive disorder. Also, after adjusting by various confusing factors, the association only persists for those who were pre-frail. In summary, despite having a good treatment against HIV, people living with HIV suffer early development of health problems, which are traditionally seen in the other persons. These health problems can be ahead until a decade, which underlines the importance of implementing strategies for the identification of geriatric syndromes in younger population having a chronic disease that seem to accelerate of aging. What are the perspectives for the care of people living with HIV and who are now aging? It is already clear that combined antiretroviral treatment prevents people from reaching advanced stage of the disease or developing AIDS. However, even with access to the best treatment, I hope that there is a clear that living with HIV seems to have a very important interaction with the aging process, which includes the early development of geriatric syndromes. Fortunately, the approach of people living with HIV seems to be changing globally, and there are more and more centers that take in account the problem of old age among younger people. Frailty is a state that can be identified early, where the affected person can benefit from an individualized approach and according to its needs. And this approach includes the application of a comprehensive geriatric assessment with the purpose of identifying predictors of poor prognosis for people's health and offering an adequate alternative. It seems necessary that the multidisciplinary approach centered on the person must change for a multidimensional approach, also focusing on the person, where in addition to control for HIV infection, the treatment of other concomitant infection and chronic disease, other fundamental aspects for the health of the older person must be taken in account, including the determination of functional status, avoid polypharmacy, explore psychopathology, and favor a good quality of life. And as the Dr. Wiley and Rodwood are recommend in this interesting reflection published recently, geriatric HIV medicine is born, and all the necessary efforts must be made to include the competence and skills developed for the case in geriatrics within immunoinfectology. We must make efforts to change the classic approach of internal medicine that normally treats people with HIV alone and usually focus almost exclusively on the control of the disease. But we must understand that people are aging with HIV, so the geriatric care is imperative, and attention of these people must be focused on the conservation and recovery of functional status. Important steps has been given across the world. The European AIDS Clinical Society has published recommendation for the inclusion of comprehensive geriatric assessment during the care of people living with HIV since a few years ago. And similar efforts has been made in North America, including Mexico, who has recently presented its guidelines for the care of other adults living with HIV. Then it seems that we are on the way to give better care of these patients. It seemed difficult that the geriatricians are all the time directly involved in the care of in the care of all the people living with HIV and who are now aging. And therefore, according to the position of different associations and societies, we as geriatricians must make the effort among other health professionals and other health colleagues to be interested in identifying geriatric problems among these people. We must make effort to sensitize other health professionals in the problems associated with aging. Undoubtedly, the first step will underline the value of the comprehensive geriatric assessment as the beginning for the identification of problems susceptible to an intervention, which is expected to improve the quality of life of people in this final stage of their lives. Among these health problems, frailty has a very nice role, a very important role, and we must continue working until it is taken systematically in account. So the specialists in infectious disease and geriatricians must work together. And in conclusion, people living with HIV face different challenges for their health as they age. It is possible that living with HIV accelerate or accentuate changes seen during aging. Seniors who live with HIV have a very high frequency of comorbidities and also early development of geriatric syndromes. We must all participate in promoting the change for the care of these people and promoting the transition from the challenge given by the treatment of an acute disease to problems related to the attention of a chronic disease. We hope that with the passage of the time, the care of the people living with HIV includes in a first stage the comprehensive geriatric assessment, and the geriatric syndromes can be addressed with everything we have learned in our discipline in recent years. And I only have to thank you for your attention, and I hope I can have transmitted you how important this issue is in an increasingly complicated world. Thank you, and I will be available for the round of questions and answers. Thank you very much.
The question and answer. The first question is, thinking about the development of research that generates an impact on other people's quality of life, what do you think are the most important outcomes for other people with HIV?
I think that, thank you very much for the invitation, first of all, and thank you, Dr. Manzotti, to be here once again. And undoubtedly, I think that the main outcome to explore in the clinical trials or in research in general, is the development of disability and dependency. These two items, outcomes, are the relevance for the autonomy and for the quality of life among older persons, and obviously among older persons living with HIV.
Perfect. Well, I have another question here. What is the best strategy to address inequities in older people living with HIV?
This is a good question. I think that the information on general population is one of the most important steps. And even in professionals of health, the concept of aging, first of all, and then there exists subpopulation of the segments of population with special needs. So we need to point the care of this population, tailor it. We need focus the specific needs from this population, and the minorities, for example, the people living with HIV, or for example, the racial minorities in some countries must be addressed the special way. But I think the information and the diffusion, and this Congress, for example, permits spread the word about the special needs of this segment of population.
Thank you. Well, Evelyn Campoverde asks, thank you very much for the presentation, Professor Avila Funes. Could we consider the same treatments that we currently apply to frailty in the elderly for people living with HIV?
Well, thank you for the question. If the question is about the medical treatment, we need to choose the correct treatment according to the specific needs of patients. For example, we know that some drugs must modify the metabolism of glucose, another for lipidemia, and other medicaments allow the osteoporosis for this action directly in the osteometabolism. So, or depression, or we must consider the portrait of the participant or the patient to choose the right treatment. Obviously, the skills learned from geriatrics must be applied in this population. That means to choose the most simple schema of treatment, one tablet one day, for example, and the treatment of chronic disease in parallel. And we must highlight also the modification in lifestyle and promote the healthy aging, the exercise, the diet, etc. So in conclusion, in brief, we must choose the appropriate schema of treatment according to the patient, and don't forget the other measures, so that they are very important, so all have the same importance for all Asian population.
Okay, perfect. Well, I have another question here. How much the burden of caregivers change in those caregivers of older people living with HIV versus those who care for older people without HIV?
I don't know the answer because we are, this is a new phenomenon. I think that in the following years, we will know this problematic, but I think that will be the same or more or less the same, in addition of the stigma or another things running in parallel with this kind of specific of patients. But we are now at the time precise to promote the healthy aging. I insist the older adults living with HIV are not exempt to being with an aging, healthy aging. So we need all the professional of health must be their effort to promote it. No?
As the title is, a new challenge for all.
Yes, of course. And the new concept maybe is the survey and to watch the quality of life of these patients. Until now, the adequate control of the disease according to CD4 or viral load and the adequate access of treatment are the principal goals. But now we must care about the quality of life for every patient, and we must include in our evaluation we need to explore the quality of life in patient and act according to their specific needs.
Okay, perfect. I think I had the last question here. Graciana Alessandrini asks, congratulations on your talk. Your experience, do you think that comprehensive geriatric assessment is a good tool for infectologists to guide antiviral treatment of this patient? Do you think there should be clinics or infectologic geriatric co-management of these patients?
I think, thank you for the question, but I think the work together with the specialist in infectious disease is mandatory. Our experience in our center is the work with the immunoinfectology clinic is that our skills in the care of patients with HIV must modify the choice of treatment or the surveillance along the time. So yes, I think that we as geriatrician or gerontologists, for example, we must make the effort to insist in the other practitioners. I am speaking from infectology, disease specialists, oncologists, or general medical generalists, etc., to promote our experience and the contribution of geriatrics medicine in this field.
Well, Dr. Avila Funes, I think we run out of time. So thank you very much for your conference and for answering the questions of the people. Thank you very much. And I'm sure we are see you in another conference.
Thank you very much for your attention. Thank you.